started. Yeah. We can start.
Good evening, everyone, and welcome to our monthly learning sessions of case presentation and case discussions from Karnataka chapter Spice Route. I'm Dr. Suprita. I'm state lead for Spice Route Karnataka, and it's a very encouraging to see such a number of participation and early logins for the session. It pushes us more to keep doing the same. So let's start the session for today. That is examination of normal neonate. We have our presenter, Dr. Varsha. She's a second year family medicine trainee from Haveri District Hospital. Welcome, Dr. Varsha. And we have a moderator, Dr. Srividya Raghavendran, who's HOD, Family Medicine Department, Bangalore Baptist Hospital. Welcome, Dr. Srividya. So without wasting much of time, let's start with the session. Varsha, you can start the presentation.
Thank you, ma'am.
Before Varsha starts the session, Dr. Suprita, do you want to say how the participants are going to address their queries and how are we going to do any Q&A?
Yeah, so I request everybody to post your concern of any questions if you have in the chat box, and probably at the end of the session we'll address the question, and if it is relevant to the examination or the session that is going on, it will be addressed then and there.
Right.
And
are they okay to unmute and answer the queries if they have?
I request everybody to keep yourself muted so that the session should not be interrupted, and we'll have a smooth presentation and an interesting discussion.
Yeah, thank you.
Oh my gosh.
Thank you, Dr. Shivya, for that.
Can I start it, ma'am, now?
Yeah, you can start.
Good evening to everyone. Today I'm going to do a newborn case presentation. Coming to the demography, I'm presenting the case of baby of Prema, male baby with a gestational age of 39 plus 4 days, now 28 hours old. Mother is a 24-year-old primate, born out of non-consanguineous marriage. Parents are Hindu by religion, residing from Ranebenur. Baby was born on 12/7/2023 at 5 a.m. in the district hospital with birth weight of 2.8 kg. Baby is in postnatal ward for routine newborn care, and the informant is mother and is reliable. They are having a married life of 1.5 years, and it was a non-consanguineous marriage. Her LMP was on 8th October 2022, and EDD is on 15/7/2023. Mother's blood group is B positive. Coming to the antenatal history, born to a 24-year-old primate, LMB was 8th October 2022, and it was a spontaneous conception, and they confirmed the pregnancy by urinary pregnancy test after 1.5 months of amenorrhea. Patient is a registered case in district hospital, and her pre-pregnancy weight was 39.5 kg. Coming to the first trimester history, after the confirmation of the pregnancy, they started with the folic acid supplementation, and number of ANC visit was only one during the first trimester, and they had taken one dose of TT was taken in the first trimester, and the dating scan was not done. There was no history of hyperemesis, fever with rash or lymphadenopathy, pain abdomen, dysuria, or any history of any drug intake or any radiation exposure. Coming to the second trimester, patient was given iron and calcium supplements, and the quickening was felt by around 20 weeks. And in the second trimester, they had taken the second dose of TT. and the nuchal translucency and the anomaly scan was done and was said to be normal. And there was no history of hypertension or any history suggestive of gestational diabetes. In the case of third trimester, the fetal movements were perceived well, and the growth scan was done and was said to be normal. And patient continued with the iron and calcium supplements. There was no history of decreased fetal movements, any discharge or bleeding per vagina. And so the patient had total 5 ANC visits, 1 in the first trimester, 2 in the second and the third trimester. And the pre-pregnancy weight was 39.5 kg, and like post-pregnancy it was 49 kg. Coming to the intranatal history, it was a spontaneous
Dr.
onset.
Varsha, can we hold for a minute?
Yes,
Yeah.
ma'am. Yeah.
Go back to the first few slides. Before we go to the next stage of her delivery, let's have something which is important. One is how do you think a newborn case presentation is different from your regular case presentation?
Like in this newborn case presentation, the history of like we have to start from the history of the antenatal history is more important. In newborn case presentation, mainly we have to concentrate on the antenatal history, like what happened in the first and second and the third trimester.
Okay. And why it is important to do about the antenatal history? What is the key information we are looking at?
Like the
So let's say that let's go from your history, yeah? Let's say from the first trimester when she confirmed the pregnancy. Uh, you have mentioned about so this is perfectly fine. Her pre-pregnancy weight, spontaneous conception, that's perfectly fine. And why is this part is important? Yes, somebody has written about it gives us an idea whether it's a high risk pregnancy. That is one point. Definitely, that is important. And what are the other significant points which we could derive from your slide?
from this slide, ma'am.
Mm.
Like we can understand whether like they have took any, like whether they have taken any infertility treatment or not, and whether it was a booked case or registered case,
Mm-hmm.
and also about the age of the mother is really important to know whether it will belong to high
Yes.
risk or
Yes. So one is about identifying about the high risk pregnancy. Second thing is about along with the high risk pregnancy, what are the key component? Age of the mother, mode of conception, whether it was spontaneous or through IUI and things like that. Three, whether it's a registered case or not. Another important thing in your slide is the weight of the mother. Are you happy with the weight of the mother, pre-pregnancy weight?
Except the presenter and the moderator, I request others to please mute once you enter the meeting.
Dr. Suprita, there are some videos coming up. I'm not sure from where that is coming.
I'll just check and I'll mute them.
No,
Yes,
I
please.
think somebody has entered. I've tried removing 2 people. I've tried removing them. I couldn't see any videos though. Did someone see from which login it was?
I'm not
They're
sure because
changing.
they are.
Jyotika, they are changing the names. That is a
Ah,
different name system.
okay. Vishnu, if you can help me, let us just keep a watch on the participants list. So somebody who unmutes will be able to identify it. Till then, of course, I'll lock the meeting. I mean, everybody is on mute. Nobody can unmute. So I'll disable the unmute option. Only Vidya and Dr. Vidya and Dr. Varsha can unmute.
Yeah, that will be better.
Okay. Okay.
Okay. Dr. Varsha, let's move on to the next slide, please.
Okay.
All right. What are the key components in the first trimester? What do you look? Let's say you're asking a mother who just delivered a baby, and there are certain important things you're looking in the first trimester. What are the key important things?
One thing, ma'am, we can ask about the dating scale so
Yeah.
that we can confirm the almost confirm the ADD of the patient.
Mm-hmm.
Second
Okay.
thing about the whether they have taken the folic acid supplements they have taken or not,
Mm-hmm.
and about the about increased vomiting. Then about the to know about the torch infections like fever with the rash or lymphadenopathy we can ask.
I know this sounds like an undergraduate question. What are the components of torch infection?
Ma'am,
Can you abbreviate the torch?
okay. Toxoplasmosis, others, then rubella,
Mm-hmm.
then cytomegalovirus, then herpes.
And what about S transport? Hello?
Yes, ma'am. It's
S for what, ma? Toxo, okay, rubella, others. Syphilis, right? Yes, yeah. Radiation exposure, yes, that's important. Fever with rash. Let's say when a mother tells that she had a trimester, she had a fever with a rash. What are the important questions you'll ask for? Which type of fever with rash is significant in the first trimester, which will have an impact on the baby in the later part? Yes, Dr. Hinna, that's correct. Anybody else?
it,
Dr. Asha, you can say no problem.
like in case of rubella,
Mm-hmm.
like chickenpox.
Yeah. How is it important? Let's say rubella, what happens if it's a rubella kind of a rash? What are the complications expect to see in the baby?
In case of rubella, we can expect for cardiac defects like cataract.
Okay. Someone mentioned congenital rubella syndrome. What are the components of it? So before you say the word, we should know what are the components of it. So please tell who's going to be ready to answer that. Hearing defect, yeah. Deafness, yes. Deafness is one component. What are the other components of congenital rubella? Cardiac disease, what is a common condition we see in a cardiac disease for rubella? Cataract is one, sensory neural hearing loss, PDA. Yes, correct. That's great. And what happens if it's a chicken pox?
Congenital varicella syndrome.
Mm-hmm. Does it happen in first trimester or second trimester? When do we start worrying? Others can also answer. No problem. After 28 weeks? Is it Dr. Kirti? Anyone else have answer for it? Third trimester. What are the components of congenital varicella syndrome, Dr. Varsha? Right. Anyone wants to answer that? Okay, I'm going to keep this. You're going to come back and tell me later on. Yeah? Lymph hypoplasia, that's correct. All right. So there are a few important things in the first trimester which we need to make sure we ask those questions. You have written all the important things. That's perfectly fine. It's a good practice to have a format on how do you take this history, dating scan, medicines, which includes TT and folic acid, and any symptoms during thing. One more thing to check is the dysuria, which you have mentioned. UTI in pregnancy, especially in first trimester, can be problematic. So that is something we should be aware of. Yes, next slide, please. And drug history is important. Why the drug history is important? Which are the common drugs which are commonly used nowadays by women of different age group, which can have an impact.
Antiepileptics.
Yeah, correct. Valproate, yes.
Then alcohol, like fetal alcohol syndrome.
Retinoid. Somebody has written retinoid. That's a very good one. Thyroid. Are you thinking about hyperthyroid then? Hypo is not a problem. If it's hyperthyroid, carbimazole and things like that, it's a problem. Another common one, which we generally see women taking, warfarin, yes. Antibiotics, certain antibiotics, yeah.
Tetracyclines.
Tetracyclines, yeah.
And gender, like
So antibiotics, okay. We have seen anti-epileptics, antibiotics, hyperthyroidism. What else? One statins, yeah. Another important thing which is commonly we used in our regular practice. Antihypertensives, right? That is something, especially ACE and ARB inhibitors. We have to be careful about it. Yeah, that's correct. Let's move to the second trimester.
okay.
So, what is quickening? This is the first pregnancy for the mother, right? So, how would she describe? What did you ask mother?
Like whether she had felt any like flickering moments.
Hmm? First moment of the baby felt, yes. That's something which is commonly asked, yeah. And the first fetal moment perceived by the mother. And usually majority of the mothers will be able to tell that. And for multi, they start perceiving early. For primary, 20 weeks is the rough estimate. We generally see that. Anomaly scan is important. And what are the other symptoms we can expect in the second trimester? First trimester, we thought about hyperemesis gravidarum. What is a common presentation in second trimester for mother?
About the pedal edema.
Yes, pedal edema. Yeah. What will you ask? How is it different from the regular edema?
Like if it is physiological edema means by after taking the rest, the edema will subside. But if it is due to hypertension or preeclampsia, it won't subside even after taking the rest.
Yeah.
And physiological will be mostly only up till the ankles.
Hmm.
And in the due to preeclampsia, it can move above the ankles.
Right. And what are the other symptoms? One is pedal edema. What are the other symptoms? Gastritis can be some. Yeah, that's one thing. Yeah. What else? What about headaches, visual? Yes, blurring of vision. All symptoms of preeclampsia we should start getting. Frequency of picturation can also increase. That's correct, Dr. Amprasad. And any spotting, never forget to ask spotting throughout the pregnancy. It's important to check. Yeah. So that is an important symptom to check. Mm, yeah, medicines, iron, calcium, supplements. Okay, let's talk about GDM. I know this is not a gynae case, but let's quickly talk about the GDM. Let's say the mother has, at what age, at what time of the pregnancy should we do a GTT? And when do we do GTT?
Like around 24 weeks of gestation.
24 weeks? What is the latest recommendation?
Even in the first pregnant, like first trimester, if the patient, like we can go for RBS, ma'am.
Yes. So, because in our place, especially in the peripheral settings, the frequency of mother coming for ANC may not be as advised. So, whenever we get the opportunity, it's a good practice to check it. The RBS can be the first step, and if there is abnormality, then GTT can be done. We don't have to wait for 24 weeks. Okay, let's move to the next slide. Okay, let's go for the symptoms wise. Third trimester, what symptom to look for?
Like in third trimester, we can ask about the fetal movements,
Mhm. Okay.
whether there is any PV, like leaking PV, any bloody discharge from the per
Mhm.
vaginally, like a pain abdomen.
Pressure symptoms, yes, Dr. Aparna. And when you say fetal movements, how often and what exactly you'll ask? Will you say, is your baby moving well? What exactly you will look for?
Uh, like after the meals daily, like morning, afternoon, in the night, for 1 hour, they have to count the fetal movements.
Mm. Yeah, count the baby movement. And what is normal? What is abnormal?
It should be more than 12 in a day.
Yeah, okay, that's perfectly fine. And if it's a twin pregnancy, should we double the number, 24?
No, same almost.
It will be difficult to do the difference. It will be more or less the same. So we can't predict the fetal movements in twin pregnancy. Yeah, at least 12 movements per day. That's perfectly fine. And then how often? See, according to the WHO guidelines, what is the normal number of visits, antenatal visits? Minimum number of antenatal visits.
Minimum should be 5 months.
Mhm.
Like
Okay. 5 or 8?
minimum is 5 months.
Mhm. Somebody has written 8 in the chat box. Minimum is 5. First trimester 1, second and third trimester 2 and 2. 8, it's up to the mother. If it's a precious baby, then towards the later part of the pregnancy, the frequency of the visits can increase. 2016, it was WHO says 8. I remember it is 5. I can check it again. And one is the fetal movements. Next is the symptoms. Then growth scan, iron and calcium. What are the common complications you can expect in the third trimester?
Bleeding can be expected, ma'am.
Okay, bleeding is one.
Yes.
Yeah.
Then, like we can PROM, premature rupture of the membrane.
Yeah. Okay. Yeah. PIH, preeclampsia, prom. Yeah, that's correct. Yeah. Okay, that's fine. And okay, move on to the next slide. We'll go to the baby part.
Okay, coming to the intranatal history, it was a spontaneous onset of the labor, and the duration of the labor is 14 hours. So it was a full-term normal vaginal delivery, and the lighter was clear. Coming to the postnatal history, birth weight was 2.8 kg, and the weight on the day of examination was 2.7 kg. And the baby cried immediately after the birth, and routine newborn care is given. And the baby is breastfed within 30 minutes of the delivery. and the baby passed urine and meconium within 24 hours of the life. Coming to the feeding history, baby is breastfed every 2 to 3 hours and each feeding lasting for around 20 to 30 minutes. There was no complaints of any feeding difficulties, and baby sleeps for 2 hours post feed and passing urine around 6 to 8 times in a day. Coming to the immunization history, like vitamin K, BCG, hepatitis, and OPO was given. There was no significant family history, and according to socioeconomic history, patient belongs to the upper middle class by the modified Kukuswami's classification. Coming to the summary, a 28 hours old male, a tame male baby with birth weight of 2.8 kg, belonging to upper middle class, who is exclusively breastfed and immunized will be born to a non-consanguineous marriage by normal vaginal delivery without instrumentation with uneven full pregnancy is admitted for normal routine newborn care. Next part is exam.
Okay. So before we go to the examination part, let's look at the baby as such, right? So normal vaginal delivery, no major complications. Duration of the labor is 14 hours actually. And there are few things which you have written in this, which is very relevant and very important. Let's go about what is Apgar score. I'll start with the basic.
That we use to assess the baby. Apgar scoring in that one A is for appearance, then pulse rate, then grimace, then respiratory movements. We have to assess at to 1 and 5 minutes. If it is more than 7 means it is normal. If it is less than 7, we have to go for the resuscitation of the baby.
Yes. So this is important. So I presume you work in a, district hospital, right, Dr. Varsha?
Yes.
So
Yes.
you attend deliveries?
Yes, ma'am.
Right. And what is the protocol there for you? So who attends the delivery with you? You attend on your own or you have a senior with you?
Mostly co-pages will be there.
Co-PGs will be there. Okay. And let's say this baby at 1 minute had Apgar score of 6. What will you do?
Then again we have to assess every 5 minutes, ma'am, till we get the score of 7.
Okay. So up to how long can you wait before further intervention?
20 minutes, ma'am.
20 minutes. Okay. And 20 minutes you'll wait. That long? Is it too long or too less? Anyone else wants to answer this question? Yeah. So 0, 1, and 5 minutes, and maximum is 5 to 10 minutes, not more than that. If the baby's Apgar score is not improving, the baby have to be shifted into NICU for further treatment. Yeah. You cannot manage with just a simple warming the baby and trying to make the baby cry. And what is the minimum requirement? How soon the baby should pass urine and the meconium? What is the deadline? Remember?
Meconium should be passed within 24 hours of the life. For urine, we can wait till 2 days, 48 hours.
Okay. And if the baby didn't pass meconium, what are you suspecting?
Any anorectal malformations we have to suspect.
Right. All right. Okay. And let's go to the next slide. So what is the Apgar score of this baby? Sorry, I forgot to ask.
Like the patient part, in the case sheet, it was written 7 and 8 months.
Right. All right. Okay. So breastfed baby, no problems at all. And at what stage or which babies do we keep an eye on the sugar levels? Do we check sugar levels in all babies?
Mainly in the babies born to GDM mothers, they can go hypoglycemia.
Okay. GDM mothers are one. What are the other conditions we check the sugar levels?
If the baby is not feeding, like not breastfeed properly, or if the baby is lethargic.
If the baby is lethargic, okay. Any other conditions?
Sorry, neither can anyone answer questions in the chat box, nor can they unmute because I don't know, people have joined this meeting and creating a scene. So it's completely locked. Only Varsha and Dr. Vidya can talk.
Understood, Dr. Jyoti.
Yeah.
Yeah.
Sorry, Dr. Nurul, you cannot unmute. I think Varsha, only you have to answer all questions now.
Varsha is going to think I'm done for today.
No.
So where is the Varsha?
Like in which babies we will go for sugar levels.
Yes. So one is the baby with the GDM mother. That's perfectly correct. We should also look for babies who are small for gestational or IUGR babies. We have to keep a close eye on the sugar levels along with calcium, and big babies as well, whose mothers may not be GDM, but they might have also hypoglycemic symptoms. These are the three important conditions we need to keep a close eye on the sugar levels. Otherwise, generally, we don't have to check the sugar levels for the babies. Yeah. Good. Next slide. Family history, this and all is fine. Yeah, you can go to examination. And sorry, what vaccines are given at birth?
Like one is at birth only we have to give injection, vitamin K we have to give. Then BCG, like we can wait till 1 year of the age. Then
1 year.
hepatitis, like BCG can be give, like it should be given during at the birth only, but we can give like till 1 year of the age.
Yeah.
And even hepatitis as early as possible or within first 24 hours we have to give hepatitis, and OPV like within 15 days.
Yeah. Okay. That's fine. Go to the examination.
Okay. Coming to the examination, baby is active and playful, and baby is lying in mother's lap in universal flexed posture, and the color is pink, and the cry is good. Both the abdomen and feet are warm to touch. Coming to the vitals, coming to the temperature, it was 98 degree Fahrenheit measured in the axillary area. Heart rate is 140 per minute, and respiratory rate is 46 per minute. And capillary refilling time is less than 2 seconds.
What is the normal heart rate for a newborn baby?
110 to 160.
Sorry?
110 to 160.
Okay. And respiratory rate?
Till 40 to 60.
Right. All right. And when do we call hypothermia? At what stage we call hypothermia and the baby needs active intervention?
If it's like less than 36 degrees Celsius.
Yes. So our threshold should be little lower in the newborn. So any baby below 36 degrees Celsius, we'll have to act immediately. We can't delay the management. Yeah. Yeah. Carry on.
Coming to the birth weight, it was 2.8 kg. Length was 46 centimeter. Head circumference 34.5 centimeter. And chest circumference 31.5 centimeter.
Have you put it in the growth chart in center?
Is no.
Right.
So
Will you do it now or will it's generally done later? What stage we should start putting it in the growth chart?
from birth we can do, ma'am.
Ideally, it's a good practice to do it before the baby is discharged home so that we know which centile the baby was when we discharged. And before we go to the next slide, what is the ideal weight loss? So I'm sure, what is the accepted weight loss? What percentage is accepted weight loss?
Within 1 week, up to 10% is acceptable, no? More than 10% is significant. And daily weight loss up to 3%, ma'am.
Right. And what is the common cause for the weight loss?
Mainly the breastfeeding issues, ma'am.
Yeah. So feeding
And
issue is the major cause for the weight
weight loss.
loss. And of course, if the baby has any metabolic abnormalities and things like that. Okay, next slide.
Coming to the head to toe examination, heart is normal size and shape. In the scalp, there was a diffused swelling present on the right parietal region, and the anterior frenulum was 0.5 into 2.5 centimeter. There was no facial dysmorphism. Mouth and neck are both normal. Umbilicus was healthy. There was no discharge. Anal orifice was normal. Spine and limbs were also normal.
What is this scalp swelling called?
Caput, ma'am.
Mm. What is caput? What is capillum too?
Like caput due to molding will be getting caput, and it will be diffused swelling, and it can cross the suture lines.
Mhm.
And it will be resolving by itself. In cephalohematoma, it is mainly due to the new birth traumas, and it won't cross the suture lines, and it can cause physiological jaundice in the babies, and it can also disappear by itself by 2 to 4 weeks.
Right. And if it extends beyond 2 to 4 weeks, what is the common thing you should think about?
Any bone fracture we have to think of.
Right. Okay. And you mentioned about no facial dysmorphism. What are the characteristic facial dysmorphic features you're looking at?
Mainly the like in a
So let's start from the eyes, right? Like, is there a widening of the eye spaces?
colorism,
Yes. And then nose, you can have a look at it. What is the characteristic?
breast.
Yeah, that's fine. And then what other facial dysmorphic? The moment you look at the baby, you'll be able to pick it up, right? What is it you will see?
Cleft
Cleft lip, cleft palate. Yes. Cleft lip is obvious. Cleft palate, unless we open and see, we won't see. Then what are the facial dysmorphic? So chin, how is the position of the chin of the baby? And how is the ears placed? So these are the common dysmorphic features. We can pick it up, which would help us to do. And in the neck, what are the things you're looking at?
Mainly we have to check for any swellings, ma'am.
Mm-hmm. What swelling, ma?
Cystic hygroma,
Okay,
triangle cyst.
okay, that's fine. And what about umbilicus? You have written umbilicus healthy. What does that mean?
Whether the cord is healthy or is there any discharge is present or not.
How many vessels will should be there in the cord?
How many?
How many vessels when the umbilical cord, after cutting the umbilical cord, you have to check
Two,
the vessels, right?
yes, ma'am. Two arteries and one vein, ma'am.
Right. If it is only two, one artery, one vein, what does that mean?
Almost it will be normal, ma'am. Like, but it can, like, rarely it can feature of renal anomalies, ma'am.
Yes. So we need to look for it. Yeah, that's fine. Uh, Anal orifice. Why is it important to check?
For the patency,
And how is it tested? How do you test it? One way is to observe whether there is a anal orifice is there. The other way is they'll put a small catheter in to see whether the opening is there or not. There are times where people put a small finger with gloved finger inside the orifice to see whether the opening is patent or not. But those are all crude ways. Mainly it's observation, inspection, and then checking over. Yeah. And if the baby is already passed stool through that, then it is perfectly fine. And spine, what is the important thing you should check in the spine?
Any meningocele or
Yeah. Anything else?
bifida, anencephaly,
Yeah. Yeah. Perfect. All right. And in the limb, what will you check? One important thing.
limb hypoplasia, ma'am.
Limb hypoplasia, yeah.
Then
In
in
the
the
lower limb?
ma'am,
In the lower limb?
ಇದು like CTV, ma'am.
Clubfoot, yeah. It's important to check clubfoot, yeah. Okay, next slide.
Coming to the systemic examination, respiratory system, normal vesicular breath sounds were heard, and air entry was equal on the both the sides. Cardiovascular system, normal S1, S2 heard, and there was no added sounds. In the abdomen was soft and there was no organomegaly. In the CNS examination, child is moving all the four limbs and the tone was normal. Coming to the neonatal reflexes, the glabellar tab was present, rooting and sucking reflex present, Morose reflex present, palmar grasp was present, and asymmetric tonic neck reflex was present.
Okay, how will you do Morose?
Ma'am, we have to like support the back of the baby with the one hand, and we have to hold the support the neck and the head of the baby. Then we have to like ventral. What is
So slightly drop the baby back a little bit and see how's the response. What
extent
response
about
from the
the
baby?
abduction and the extension of the upper limbs.
And what happens to the lower limb?
It extended, ma'am.
Yeah. And when does it appear and how long does it stay?
It appears by 28 weeks of gestation, ma'am. And it will be disappearing by 3 to 6 months. And if it is persisting months, we have to suspect cerebral palsy.
Right. Okay. It's 28 weeks or 34 weeks? I thought it was 34 weeks. I may be
Abduction
wrong.
will be present by 28 weeks, ma'am. Extension
The
by
whole three components.
yes.
Right. And ATNR, what does that mean? How will you do it?
Like the baby will when we turn the head of the baby to which side the baby's head is turned, that side will go for extension and the opposite side will go for flexion.
Right. Okay. And so neonatal reflexes are present till 3 to 6 months. After that, what does it mean? There are some reflexes, they go off early, no? Which is the reflex which goes off early among all this? Glabellar tap can go up early, yeah? And also sucking reflex can continue for longer as well in some infant. That is something which is there. Okay, next slide.
Summary, ma'am. 28-hour-old term baby boy, appropriate for the gestation age, born out of the normal vaginal delivery, with birth weight of 2.8 kg, who is exclusively breastfed and immunized till date, with no respiratory distress or congenital anomalies, is admitted for the routine newborn care.
Right. Okay, so Dr. Varsha, we'll have few more things before we finish the session. Let's say you mentioned about cephalometoma and that leading to jaundice, right? If there is persistence of at what age is it normal to get physiological jaundice? And tell me the difference between physiological and pathological jaundice.
Like if it is appears within 24 hours of life means it will be most physiological pathological jaundice, and after 24 hours of life it will be physiological jaundice.
Okay.
And
And what are the common cause for pathological jaundice?
common causes in case of ABO incompatibility, RH incompatibility, in G6PD deficiency, in case of like if like Gilbert syndrome, hereditary spherocytosis.
Yeah. So all the metabolic causes, it's very common to have with pathological jaundice. Physiological jaundice, there are two types of physiological jaundice. What are those two?
Breast milk and breastfeeding jaundice, ma'am.
Mhm.
Breast milk jaundice is mainly due to the content called pregnenolone. It will inhibit the conjugation of the
Mhm.
bilirubin. And breastfeeding jaundice is mainly due to inadequate feeding.
Mm. Right. And how would you manage? What would be your advice to the mother as a family doctor? What would you advise? Because especially if it's a first time mother, she'll have a lot of queries, right? How do I manage? The baby will be cranky and then she will also be extremely tired. So what advice will you give her?
Like in jaundice, they have to continue feeding now.
Mm-hmm. Okay, continue the feeding. Yeah.
And if the like they have to come back if it is if the yellowish discoloration is present even in the soles and palms, they have to consult.
Mm-hmm. Okay. See, the basic thing is reassuring the mother that it is physiological. The baby will get better. So it all depends upon how the feeding is managed, how the hydration of the baby is taken, and regular monitoring. So that kind of reassurance will definitely make it work. That is first and foremost. Number two, um, if there is an issue, what are the common feeding problems you will encounter? Let's say a breastfeeding mother. What are the common issues she will have in feeding?
Inverted nipples,
Yeah, that is
then,
important. Yeah,
then sore nipples,
sore nipples. Yeah,
then the weight loss of the baby. They can.
yeah. Weight loss of the baby. Yes, that will also deteriorate a baby sucking capacity because the baby will not have energy to take enough milk and
Then
exhaustion from the mother also. No, mother if she's not eating enough, that can also cause an issue. So these four things, if we address, which are very very simple to address, if that can be addressed, then that will make a big difference. So that is one. So jaundice is something which you need to be aware of for the exam. Head to toe examination. All the one important thing which a lot of times we ask is, I hope you know what is milia, what is erythema toxicum.
physiology.
Okay, what is erythema toxicum?
That reddish discoloration seen.
Hmm. It looks quite angry looking, right? But how would you differentiate that with septicemic pustules?
Ma'am.
So the erythema toxicum will also have whitish, like a pastel kind of a thing with a red base, right? In
Yes.
multiple, usually it happens within first 2 to 7 days, you would see that, and it settles on its own. But how will you differentiate that from any pathological rashes? Because that will also look red and angry looking. So how will you differentiate those two? So it's important to look at the other parameters, right? How are the vitals? How is the feeding of the baby? How's the baby overall? So if erythema toxicum, it's a very simple and the look of it is very easy to pick it up. And so overall, the baby will be well. and usually it settles in about 7 days. What is Mongolian spot?
Like bluish discoloration, ma'am, mainly due to the accumulation of the neural cells. And normally it will be disappearing by around 1 year of the age.
Right. All right. Okay. That's great. I think you did very well, Dr. Varsha. So basic thing is antenatal history. We'll have to focus a bit more on symptoms, signs, and what investigations are required in each trimester and what medicine needs to be given. So each trimester, if you could remember it and present it that way, you won't miss any points. That is for antenatal history. Intranatal and postnatal is important. Newborn examination, yes, whatever you've written is fine, but you should be knowing the content of it. Let's say I was asking about the umbilical cord, I was asking about the spine, all those different parts, you should know what is abnormal, what is abnormal. And summary, that's perfectly fine. Yeah, thank you so much. I know we can't take questions today. Dr. Suprita?
Suprita, maybe you can give some email ID or something to which the students can send their questions or something like that, or on the
Yeah.
PG group.
I'll just share the mail ID where all of you can post your queries or the questions, and answers will be addressed. Answer will be sent across in the Spice Road groups and all the other groups as well. I will just share it.
You may not be able to. People are already leaving the thing. I don't know whether they're all the real PGs or people who've just joined. Okay. Do you want to wrap this up, Suprita?
Yeah. Thank you all for participating, and thank you, Dr. Vidya, for moderating the session. We know that this normal neonate examination is one of the simplest, though it looks very simplest, but we learned that still we tend to forget and miss many of the basic things. So thank you, Vidya, for the wonderful discussion, and thank you, Varsha, for the presentation.
I thank the Spice Route for organizing this. This is really an amazing way of connecting with the residents. I would request whoever is there today, please participate in our DNB webinar sessions also. We have a lot of things happening there as well. Both diploma and DNB residents can come and join that. And thank you all. Have a good evening. Thank you, Dr. Varsha. Good work. Keep up the good work.
Thank you, Dr.
Thank you,
Varsha.
Varsha.
Nice one.
Thank you.
Thank you, Vidya. Good night, everyone.
Thank
Good
you.
night.
Good night, everyone. Bye bye.
Good night. Bye-bye. Bye.